Hello and welcome back to GP Stuff, where our aim is to try and cover the RCGP curriculum in video format. This next lecture is on secondary prevention of cardiovascular disease. Recall that secondary prevention is started after the cardiovascular event has already occurred to prevent further complications. There's three components to secondary prevention then: cardiac rehab, lifestyle modification, and medications. Let's go through each in turn. Cardiac rehab is an intensive program involving MDT input that started while the patient is in hospital recovering from their cardiovascular event. The aim is to get them back to as full a life as possible, and it starts off with patient education to help people understand their illness. Next is counselling by psychologists and dietitians to help modify mindset and eating habits. Then there's OT and PT input to help them get back to a level of physical activity such that they can do their ADLs independently. You can find more if you wish on the British Heart Foundation website. There's a link in the video description below. Moving on next to lifestyle modification, there's four components to this, which you can see here: smoking, exercise, managing alcohol, and a Mediterranean diet. Remember these with the mnemonic SEAM. If someone's bursting at the seams with cardiovascular disease risk factors, dam up those seams. Let's talk through all of these one by one. So, smoking. Use the VBA, the very brief advice approach that starts off with asking a direct question. I understand you're smoking, is that correct? If they reply in the affirmative, advise support and drug therapies together. Offer assistance if they want referral to the local smoking cessation clinic. You can find a link to the National Centre for Smoking Cessation and Training in the video description below for more on the VBA approach. Management options for smoking involve counselling and medications like nicotine replacement therapy, varenicline, and bupropion. Next, exercise. As we know, exercise is the single best therapy anyone can do to make themselves healthier. It's noted as evidence-based treatment or prevention in 39 different UK national guidelines. Running for fun, even just an hour a week, can reduce cardiovascular mortality by 55%. A large meta-analysis in the BMJ showed exercise was at least as good as drugs for secondary prevention for everything except heart failure, where drugs took a slight lead. Check out the link in the description below for more on this. Current guidelines recommend 150 minutes a week of moderate intensity or 75 minutes a week of high intensity exercise. Help people find something they enjoy doing and maintain regular follow-up to monitor progress. On to alcohol. Drinking more than 14 units a week can lead to an increased risk of cancer and dementia. See links in the video description below. But this is why NICE reduced their guidance from about 20 units a week for men down to less than 14 for both men and women. Screen using the Audit C score and do a full audit questionnaire if they score 5 or more. If they score between 5 and 7, encourage cutting down and follow them up. If they're an 8 or above, consider signposting to resources like the NHS Change for Life website and refer them on to your local drug and alcohol support team. Patients with alcohol dependency should also be on lifelong thiamine or vitamin B co-strong, depending on local guidance. Now, the Mediterranean diet. This is a diet that's very similar to the government's healthy eating advice in the Eat Well guide. It's high in veggies, starchy foods, and unsaturated fats, and low in meat and dairy. You can find more on this on the NHS website, to which I've put a link in the video description below. Speaking of food, let's move on to the meat of the matter, as it were, the medications. You can remember these with the ABCDEs mnemonic. Let's go through them one by one. The A in the mnemonic then is for ACE inhibitors and antiplatelets. ACE inhibitors are given lifelong on maximum tolerated dose as per NICE guidance. The antiplatelets, however, depend on if they had a heart-related cardiovascular event like an MI or something non-heart related like a stroke. For heart stuff, patients get aspirin plus minus another antiplatelet for 12 months. This is usually secondary care led, but people who have had a PCI often get prasugrel along with the aspirin. I remember this by thinking P for PCI, P for prasugrel. For non-heart related cardiovascular events, large studies have shown clopidogrel to be better than aspirin, so that's now recommended first line. The B then is, as always in cardiology, for beta blockers. Give these again at the maximum tolerated dose and aim to get a target heart rate below 60 beats a minute. Duration of treatment is usually 12 months, but continue lifelong if they have heart failure with reduced ejection fraction. As we know, we can't give beta blockers in people with asthma. If our patients have contraindications, then we can use the C. And the C is calcium channel blockers, but only use these if beta blockers are contraindicated and they have a normal ejection fraction of between 50 and 70%. On to something I wasn't taught in med school, DOACs. Interestingly, we now give rivaroxaban plus aspirin to patients with stable coronary artery disease or symptomatic peripheral arterial disease, but only if they have a high recurrence risk of ischemic events and a low bleeding risk. Let's take a step back for a second and define these terms. Recurrence risk for ischemia is high then if patients are over 65 years of age, have had atherosclerosis in 2 or more vascular territories, or have 2 or more of diabetes, smoking, an eGFR between 15 and 59, heart failure, or previous non-lacunar ischemic stroke. Bleeding risk is calculated with an Orbit score, which has to be less than 2 or less actually, to be called low risk. The evidence for low-dose rivaroxaban comes from the Atlas and Compass trials, which showed rivaroxaban plus aspirin improved outcomes after ACS in patients with high ischemia risk and low bleeding risk. Note the Compass trial, where the absolute risk of major adverse cardiovascular events went from 6% to 4%, with a number needed to treat the NNT of 71 to prevent one major event in about 2 years, and an NNT of 105 to prevent one death in 2 years. But what about major bleeds, you ask? Valid question. The risk seemed to increase from 2 to 3% in the Compass trial, but there was no significant increase in mortality. On to the E for eplerenone. Spironolactone is no longer first line, but people can stay on it if they're tolerating it well. Eplerenone, however, is now recommended first line for heart failure with reduced ejection fraction after an MI. Start this after they've been established on the ACE inhibitor and introduced cautiously with regular use needs to monitor renal function and potassium. Finally, the S for statins. Atorvastatin 80 mg once at night, aiming for an LDL below 1.4 is advised. If they're not reaching this target or not tolerating statins, consider starting ezetimibe. Ezetimibe is a drug that inhibits intestinal absorption of cholesterol, but as such commonly causes GI upset. And that's it for today, folks. Remember cardiac rehab with PECs, physical activity, education and counselling, lifestyle advice with SEAM, and the ABCDEs of medications. If you found this video helpful, National Guidance also recommends liking, commenting, subscribing and sharing this video. Take a gander at the video description for more resources and have a lovely, safe and happy new year. See you in the next video.